Hi, I'm Dr. Kivett in Santa Rosa, California. I'm board certified in plastic surgery and dermatology and have had extensive training in hand surgery with a fellowship with two doctors, one an orthopedic surgeon and one a plastic surgeon, both of whom concentrated nearly exclusively on hand and arm surgery. Today I'd like to talk to you about nerve compressions. These are very common in people, especially with today's overuse syndromes. That is to say that people who are typing hundreds of times uh, an hour and a minute and thousands of times, of course, in a day, that frequent movement back and forth in the hand is putting a lot of stress on the tendons. The tendons will swell. What's called the tenosynovium, meaning this mucousy thin lining on top of the tendons surrounding the tendons, uh, may not be as liquidy. When you think the car that you drive that needs to have a lube job, and you think of the number of times in the course of a day that you use your hand and you don't take your hands in for a lube job, it's because the tendons, in order to slide, need to have this mucousy substance surrounding them. In doing so, then, the tendons don't swell, the lining of the tendons doesn't get thickened, and there's no discomfort of the area. That's why it's so important to be at the start of a day stretching passively like this and like this, stretching each of the 17 joints in the hand that are stretchable, and therefore you're nourishing the outer lining of the tendons. The reason that tendons are important in nerve compression is because nerves pass through various compartments in the arm and the hand, and those compartments hold the tendons in place so that they're not displaced out of the range of function in which they normally work. The tendons, if they swell, then will compress surrounding structures, whether they be arteries and, important to this discussion, nerves. Nerves themselves have a thin lining around them called a perineurium, which has little capillaries, little oxygen and blood-bearing uh, vessels that provide oxygen to the nerves. And so if the tendons in swelling compress the nerves, the outer layers, then the nerves just don't work as well. And so if you have swelling in what's called the carpal canal, meaning the wrist canal, in this location, then that's called carpal tunnel syndrome. If you have, and it's compression of the median nerve, and if you have in this compartment here called Guillen's canal, then you have swelling compressing the tendons that in that canal along with the artery, and so the ulnar nerve becomes compressed. And there's other areas too, for example, where the radial nerve, the sensory portion, comes out from this part of the hand to provide sensory innervation to this portion of the hand. These areas can frequently be compressed. In doing so, the patient perceives sensory, that is to say, numbness changes. They also experience trouble using the hand because the small muscles that are downstream from the blockage also don't work. And so the electricity coming from the brain to tell the hand to do a certain task, the signal for that does not pass through there so well, so the person can't, in the case of the ulnar nerve, spread the fingers. In the case of the median nerve, bring the thumb across, those type of things. More commonly, they experience the sensory problems where they say, oh, I've got tingling after half a day at work, or I notice at night I can't sleep well because I'm bending my elbow. And so where joints compress, for example, at the elbow, the ulnar nerve can get compressed. Where a person sleeps like this, or where a person is sitting like this, or resting their hand here, that's compressing here in the carpal canal. So all these are good examples of where the nerves are compressed. Sometimes they're compressed both at the wrist and higher up, which we call a double trouble or double trauma to the nerve, and those have to be addressed. The overuse is very common in today's world. If you see the people doing the Tai Chi Chuan exercises where they're stretching like this and stretching like this passively, continuing to do that at the start of the day, at the end of the day, and even at lunchtime, that helps foster the continuing lubrication of the tendons and helps prevent repetitive stress syndrome. Various tests that can be done are direct compression tests. For example, the physician can push on the median nerve and demonstrate tingling at that moment. The patient will say, yes, that's what I get. Or they can experience what they call pillar pain, where they're resting their hand on a flat surface and they notice that there's pain and numbness and tingling downstream from that. Those are compression tests that have some value. In testing for sensory problems, that is to say, light touch, tingling, ants crawling, all those kinds of sensations, one can simply take a very low-tech paperclip and unfurl it so that the ends are 5 millimeters apart, which is about 1/5 of an inch, and then stroke with the finger, particularly the sensory side, in this case the median nerve. And if the patient cannot perceive a difference of 5 millimeters, then the light touch sensation is at the very least deemed to be compromised. And the less and less they can feel that sensory reaction, even more so. There are EMG-NCV tests, that is to say, electromyogram nerve conduction velocity tests, that are commonly done as well, so that the physician testing with those small little electrodes measuring the timing of sending a tiny electrical signal from a known point to another known point, if that is compromised, meaning if the nerve signal slows down and is out of the range of what we would expect the nerve to show, then we know that there's a problem at that point, and that point can be localized fairly closely in order to deliver the needed treatment. Steroid injections sometimes will help, in addition to what I mentioned for the stretching exercises. Occupational therapists who specialize in hand work, who are very good, also will be able to use ultrasound, electrostimulation, and other modalities to help free up the swelling around that nerve. If these are unsuccessful, then it may be necessary, if the steroids, particularly on the injection side, which are well tolerated, don't work, then a release of the nerve compartment is commonly done, and that has a variety of different options, including full open removal of the pressure on the nerve. Some people will use endoscopes, where they will make a tiny incision on the area and divide the ligament, which comprises the roof of these compartments, and that will help as well. They have a variety of pluses and minuses, something to discuss with the physician. The important thing here to realize is that a number of these nerve compression problems can be solved with a knowledgeable intervention. There's no benefit in having to tolerate sensory deprivation. And in fact, the motor deprivation is even more of a problem, because if the nerve remains compromised, taking the electricity from the brain to the muscles in the hand and wrist, thereby not allowing the muscles to function as well, then the muscle nerve interface will actually break down. And so over time, if that's not addressed fairly early in the game, then you can have loss of recovery of the motor portion there. So I hope this has been helpful to you or someone that you know. And if you have interest in the subject, please share it with your friends. Issue us a question or a comment, which is always appreciated. Give us a thumbs up, and if possible, subscribe, so that this allows us to provide more educational information for you. Thank you for listening.